30 years old Mrs. ABC coming from Ramnagar, who has studied up to 10th grade, who is tailor by occupation, wife of XYZ, who is age 34, educated up to 2nd PU and works as an electrician. The socio-economic status is lower middle class and obstetric score of G2 P1 L1. Last menstrual period was on 13th December 2019. Expected date of delivery is on 20th of September 2020. Gestational age is 37 weeks. Blood group is O positive. Date of admission was on 26th of August and examination was done on 28th of August. Chief complaints: the lady comes with 8.5 months of amenorrhea and was admitted from antenatal clinic in the view of high blood glucose level. History of presenting illness: patient comes for a regular antenatal checkup and was found to have high blood glucose, hence admitted. No history of increased hunger, thirst, or and also there was no history of recurrent UTI and no history of vaginal discharge, no history of skin infection. Then history of present pregnancy. First trimester, it was a spontaneous conception which was diagnosed by uterine pregnancy test in the local hospital, done at 1.5 months after missed period. It was confirmed by dating scan, done at 1.5 months. Folic acid tablets taken. There was no history of excessive vomiting, fever with rashes, no history of bleeding PV or discharge PV, no history of pain abdomen. There was no history of burning micturition or increased frequency of micturition. And also there was no history of radiation exposure or drug intake. Second trimester, quickening was felt at 5th month and 2 doses of tetanus toxoid were taken at 3rd and 5th month. Iron and folic acid tablets, calcium tablets, they were taken regularly. Anomaly scan was done at 5th month and report was found to be normal. No history was suggestive of increased thirst or increased frequency of micturition. And also there was no history of pedal edema, blurring of vision, headache, epigastric pain or decreased urine output. Also no history of bleeding PV or leaking PV. Third trimester, she continued to perceive the fetal movement well. The growth scan was done at 7th month and report again was normal. No history of blurring of vision, headache, epigastric pain, decreased urine output or swelling of feet. Again, no history of bleeding or leaking PV. A patient visited antenatal clinic at 8.5 months of amenorrhea and was found to have increased blood sugars. So she was admitted. Total weight gain was around 10 kgs. Regular antenatal visits.
Okay, Neethu, that was a good presentation. We'll discuss this part now. Okay, so you have mentioned second trimester and first trimester details, no? Anytime did she get her blood test done?
In her first visit, she has got that done, ma'am.
Okay. And did you inquire whether she has undergone glucose tolerance test? Like anytime she has taken glucose powder and then she has got a blood test done before 8.5 months of amenorrhea?
No, ma'am.
So that should be specifically asked because generally, and when you're writing the first trimester, you have written that she has went to a local hospital at 1.5 months of amenorrhea. And then the next sentence should be where she is booked and immunized. She is booked and immunized at a local hospital or she is booked and immunized at our hospital. That should be written. Okay. So if she is coming to you regularly, generally in all the hospitals, including PHCs, now we do screening test at, when do we do the screening test?
Screening test GDM? 24 to 28 or first visit.
Yes. First visit, we don't say first visit. You say that screening is done as soon as the pregnancy is confirmed. Right? So we do the first screening for GDM along with all the other routine investigations as soon as the pregnancy is confirmed. Second test is done between 24 to 28 weeks. Okay. So routinely when you are writing first trimester details, you have written, you write first antenatal visit was at 1.5 months of amenorrhea and pregnancy was confirmed in the local hospital. Then she has taken regular ANC. All the other details are perfect. Then you have to write patient underwent routine investigations and she was told that the reports were normal. Okay, so that should be additional sentence. Or you should write patient never underwent blood tests. So that has to be specifically written. Same thing, even in the second trimester, you have to mention that she was continue to take regular ANC. All the details are correct in this. You have to mention she continued to take regular ANC visits and she underwent investigations, including glucose test. Okay.
Okay.
And she was told that the reports were normal. That has to be written. Okay. So because directly at 8.5 months, we don't do screening test, right? Maybe should have undergone, and maybe it was normal that time. First and second test were continually, maybe it was normal. Okay. So that has to be written here. Okay. And I feel better, don't comment on dating scan, anomaly scan. You're taking history here. So you don't know whether it was actually dating scan. You don't know whether it was actually anomaly scan. So you just write patient underwent obstetric ultrasound at 5th month and the report was normal. So growth scan. So these things we say only after looking at the reports, whether it was an anomaly scan or growth reports. Okay. And one doubt is GDM is after 20 weeks. Na? Okay. So GDM, by definition, gestational diabetes mellitus is, can you define GDM?
GDM is the carbohydrate intolerance with the severity onset for detected first time in pregnancy after 20 weeks of gestation.
Okay. So 20 weeks gestation is not there in the definition, either by WHO or by your textbook. For preeclampsia or hypertensive disorder of pregnancy, for HDP, you have after 20 weeks of gestation. Whereas for diabetes, gestational diabetes mellitus, there is no cutoff period of gestation. It is any time during pregnancy. It is carbohydrate intolerance of variable severity anytime during pregnancy. Okay. But when you get a GTT, if the values are more than 200, you say that it is probably over diabetes. It depends upon the values. So it doesn't depend upon the period of gestation. So unlike hypertensive disorder of pregnancy definition, where we say blood pressure is more after 20 weeks, for GDM, the gestational age cutoff is not there. Okay. So it is carbohydrate intolerance of any severity. It is anytime during pregnancy. Okay. And screening is, according to the guidelines, screening is, what are the screening guidelines?
According to WHO.
Yeah, no, I mean, according to Government of India, we'll talk about our guidelines first, and WHO is also the same. Government of India and WHO definitions, both guidelines are the same.
Yeah, DIPSI is followed in India, ma'am.
Yes, yes.
Glucose tolerance test, which is 75 grams of oral glucose, which is given, and then after 2 hours, blood glucose levels are checked.
Yes, good.
So after 2 hours, if the blood glucose levels are more than 120 but less than 140, it is glucose impaired glucose tolerance.
Okay.
Then if it is between 140 to 200, it is GDM. If it is more than 200 mg per DL, then it is overt diabetes.
Okay, yes. So we'll discuss the screening here. So screening is actually, as you said, it's perfectly correct. So what we are following is universal screening. That is, we screen each and every pregnant woman at least 3 times. Our minimum is recommended is actually 2 times at least you have to screen during pregnancy. One is as soon as the pregnancy is confirmed. Second is between 24 to 28 weeks. Third test is optional. Okay, between 32 to 34 weeks, you can get it done. Okay, so this is universal testing. That is, all pregnant women are tested, and period of gestation, you realize that it has to be at least 3 times in an institution. In a medical college, definitely we are doing it 3 times. And how do you do it? You said perfectly right. But the cutoff values is 120 to 139 is called as gestational glucose intolerance. Like in non-pregnant, we call it as impaired glucose tolerance, IGT. Whereas in pregnancy, we call it as GGI, gestational glucose intolerance. More than or equal to 140 above, between 140 to 200 is GDM. More than 200, it is likely that it is a over diabetes. Okay, yes, you are correct. Okay, so we'll go ahead with the next slides.
Yes, ma'am. Menstrual history. Age of attainment of menarche was 14 years. It was regular cycles of 28 to 30 days with 3 to 4 days flow. She changes 2 to 3 pads per day, not associated with dysmenorrhea or passage of clots. Obstetric history, married life of...
Just 1 minute, Neethu. When you're writing cycles, write it as past cycles, past menstrual cycles. Okay. So it's past menstrual cycles were regular. Okay. And LMP has to be written in the menstrual history. Okay. Yes. Next slide.
Obstetric history, married life of 6 years. It was non-consanguineous marriage. Obstetric score G2, P1, L1. G1, which was 4 years ago. It was a booked pregnancy at district hospital. Had a normal vaginal delivery. Female child of birth weight 2.8 kgs with no NICU admission. Baby cried immediately after delivery. Breastfeeding was started within half an hour of delivery. No prelactal feeds were given. There were no antenatal or postnatal complications of this pregnancy. The child is immunized till date. Child is alive and healthy without any developmental milestone. And copper T intrauterine contraceptive device was inserted soon after the birth of first child and was removed after 3 years.
Okay.
Then past history.
Shall we just go back to previous slide? Okay. So previous pregnancies, you have written the details correctly. Okay. So preferably don't say G1, G2 when you're presenting in the exams. You say first pregnancy, second pregnancy. When you're presenting, it's always in sentences. Okay. So first pregnancy details you have to mention. And first write the mode of delivery, everything, then mention the baby details, which you have written correctly. Okay. And because this is a case of gestational diabetes mellitus, we are concerned whether she had any GDM in the first pregnancy. So that is our concern here. So you have to mention that no history suggestive of GDM. Specifically, you have to write in this case because it's relevant for us. Okay. So generally, when we are describing the previous pregnancies, like when you're writing the previous pregnancy details, we don't write trimesters. We write antepartum, intrapartum, postpartum. Antepartum, uneventful. Okay, so that itself means that there was no history of GDM. So you have written actually no antenatal and post complications. So I think there was no history of GDM. Okay, so first you write antepartum, no history of GDM or no other complications. Intrapartum details you write, postpartum uneventful. Okay, so you have written contraception history followed by that. That is correct. Okay, so next we'll go to the next slide.
Past history. There was no history of diabetes mellitus, hypertension, asthma, TB, thyroid illness, or epilepsy. No history of surgical or medical interventions. No history of blood transfusion in the past. Family history. A mother is diabetic.
Just one more previous slide. Past history. You have to include no history of any drug allergies. For all the cases, you have to write patient is not a known diabetes or hypertensive. No history of asthma, TB, epilepsy you have written. No history of surgery, medical interventions, blood transfusion you have written. Only point you have missed is no history of any drug allergies. Okay, specifically you have to write.
I had written it in personal history, ma'am. So I have to mention it.
Generally, we write in the past history only. Okay. Yeah. Maybe you can personal history again. It will be a separate this thing. So past history can include all the medical details previously.
Then family history. A mother is diabetic in past 3 years. No history of children with chromosomal anomalies. No history of twinning in the family. No history of hypertension, asthma, TB in other family members. Then personal history. Diet was mixed diet. So the calories required is around 2,500 kilocalories. She was taking around 2,100 kilocalories. So the calorie deficit is around 18%. Appetite was good. Sleep sound and adequate. Bowel and bladder movements were regular. No history of any substance abuse and no history of any drug allergy.
Okay. So shall we discuss about diet? How do you actually calculate the calorie intake?
Yeah. So she's considered as a moderate worker, and we have to multiply 2,400, that is one dietary consumption unit, into 0.5, so that we get 2,200 kilocalories. So in pregnancy, we have to give 300 kilocalories extra. So it accounts for 2,500 kilocalories in total.
Okay. Yeah, that is actually a rough estimation for a normal pregnancy. Yes, For a moderate worker, generally that's how you calculate, and usually it is 300 kilocalories additional in the pregnancies. Okay, so that is how you calculate. For generally in for GDM and anemia, we usually calculate the calorie. Sorry.
Yes, ma'am. According to that, according to BMI,
so we calculate as per the BMI requirements and the ideal body weight. Okay, so it is generally around 35 to 40 kilocalories per kg per day. So it depends upon the body weight, and body weight is actually pre-pregnancy body weight or at the first booking visit body weight. We don't take the current body weight to calculate calorie requirement, or even any drug requirements also you never calculate for the current body weight. It is always pre-pregnancy body weight or the first trimester body weight. You calculate the kilocalorie requirement. Okay, so you have to calculate approximately around 35 to 40 kilocalories per kg per day for a normal BMI. Okay, if the patient is actually around obese, she comes in the obese group in the BMI, it will be only 25 to 30 kilocalories per kg per day. Okay, but if the patient is underweight, you can go up to 45 kilocalories per kg per day. Okay, yes, and the diet is what you have calculated is correct by 24 hours recall method. And 24-hour recall method, one person has asked out, Dr. Akshay. So 24 by recall method, it can be even after admission also you can take, though you take that maybe she would have been advised medical nutrition therapy and she's following a standard diet, but still you can calculate the 24-hour recall method. It need not be before admission or after admission, it doesn't matter. So maybe after admission, after 5 to 6 days of admission, now she's following a standard diet therapy. Maybe now it is correct. So it doesn't matter, but a diet will be always recalled by 24-hour recall method. Maybe on the first day of admission or after admission to the hospital for a longer time also. It could be corrected now, doesn't matter, but you have to take it only by 24 hours recall method, because it is difficult to estimate the calorie requirement for the previous 1 week. Nobody will remember what she has eaten before 4 to 5 days back and all that. So it's only in the last 24 hours only we calculate the calorie requirement. Okay, yes, next slide.
Then general physical examination. Patient is conscious, cooperative, and well to time, place, and person. Vitals. Patient is afebrile. Pulse rate is 82 beats per minute in right radial artery, which is regular in rhythm, good volume, normal in character, no vessel wall thickening, equal on both sides. Then BP 120 by 80 mmHg in the right arm in sitting position. Respiratory rate is 16 breaths per minute. No pallor, icterus clubbing, cyanosis, lymphadenopathy, and pedal edema. Height is 155 centimeter. Weight, pre-pregnancy weight is 58 kgs. Present weight is 68 kgs. Pre-pregnancy BMI is 24.12 kg per meter square.
Yes, you have to calculate the BMI for the pre-pregnancy weight ideally. And you think it's a good weight gain for her during pregnancy? She's 37 weeks. She has gained around 10 kgs. So is it good for her?
Yes, ma'am. Normally it is usually 11 kgs.
Generally, it is around 12 to 16 kgs is a normal weight gain. If for a normal BMI woman, the recommended is around 12 kgs. 12 to 15 kgs she can gain during pregnancy. She slightly gain little bit lesser. Okay, so it is okay. But for height 155, I think she is good. Okay, yeah.
Okay.
Can I just ask you a general question? Why do you write blood pressure in the right arm in sitting position? Which position you check the blood pressure in pregnancy?
Sitting position, supine position.
Okay, supine position, we don't check blood pressure. So pregnancy is the one condition where you check the blood pressure only in sitting position. Okay, or it has to be under 45 degrees semi-reclining position, because supine hypotension will be there. So we will never check the blood pressure in the complete supine position. Okay, it has to be either 45 degrees semi-reclining or it has to be in the sitting position. It is difficult to make 45 degrees semi-reclining. You'll be struggling to make 45 degrees semi-reclining for even for the inpatient. So we always check the blood pressure in the sitting position. Okay. Yes. Next. Yes.
Attitude for examination. Orodental hygiene well maintained and no signs of nutritional deficiency. no dilated veins over the neck. Lumbar lordosis of spine was seen. Thyroid appears to be normal. Breast shows normal changes of pregnancy. No retracted or cracked nipples and no palpable lump.
Okay.
I'll go to next slide.
Yeah, you can generally write breast, spine, thyroid normal, because normal lumbar lordosis is actually physiological in pregnancy now. So you can say breast, spine, thyroid are normal. Okay, yes. Next slide.
Systemic examination, CVS examination, S1, S2 heard, no murmurs heard. RS, normal vesicular breath sounds heard, no added sound. CNS examination, no focal neurological deficit seen. Per abdominal examination, inspection. Shape of the abdomen was globular. It was uniformly distended. Corresponding quadrants move equally with respiration. Umbilicus is central and everted. Flanks are not full. Linea nigra and stria gravidarum is present. No visible incisional scars, sinuses, or dilated veins seen. Hernial orifices are intact.
Okay, next slide.
Palpation. No local rise in temperature and no tenderness. Abdominal girth is 98 centimeters at the level of umbilicus. Symphysiofundal height is 36 centimeters, which corresponds roughly to gestational age. Leopold's maneuver. Fundal grip, broad, soft, irregular mass which suggests of breach. Lateral grip, right, lateral grip, irregular, multiple knob-like structures suggestive of limbs. Left lateral grip, continuous curvilinear resistance suggestive of spine. Then first pelvic grip, which was hard, round, independently ballotable mass, felt, suggestive of head. Second pelvic grip, it was converging, so it says that it is not yet engaged.
Okay, Neethu. So on palpation, first thing is you have written no local rise of temperature and tenderness. Okay, then the first thing will be actually what is the uterine height by palpation. So that is fundal height. Fundal height, I'm not telling symphysis of fundal height, not measurement.
Yes,
So
ma'am.
first thing you have to write is fundal height by palpation. Uterus is 36 weeks. Uterus is 32 weeks. So that is palpation. So first thing you write in the palpation is uterine height is 36 weeks. Okay. Then you mention abdominal girth and symphysiofundal height. Okay. All the other manuals you have done it correctly. Okay. So can you tell me what is the importance of abdominal girth?
We'll know if it is normal range or if it is more than the normal range. So that if the complications of GDM like polyhydramnias or macrosomia, if
Yes.
it is so it will be increased above the normal range.
Okay. Okay. So generally abdominal girth increases by 1 inch per week after 30 weeks of gestation. So after 30 weeks of gestation, abdominal girth increases by approximately 2.5 centimeter, or easy to say is 1 inch per week. It increases after 30 weeks of gestation, almost approximately 95 to 100 centimeter nearing term. So to call it as a over distended abdomen, so girth has to be more than 100 centimeters. So if you want to call over distended abdomen, like abdomen is over distended. So in that case, one clinical finding is one is uterine height is 36 weeks with fullness in the flanks, tells you that it is over distended abdomen. Second thing, what tells you that it is over distended abdomen is abdominal girth is more than 100 centimeters. Okay, and abdominal girth is not increasing adequately. That is 1 inch per week after 30 weeks. That is suggestive of either oligohydramnias or IUGR. Okay, so that is why it is important. Just okay, we'll discuss these doubts little later. So what is the important? So whenever you are doing abdominal girth, remember that abdominal girth is you start measuring only after 28 weeks, not before that, because it is important only after 30 weeks. From 30 weeks onwards only it corresponds to the period of gestation, not before that. Okay, so when you're writing abdominal girth, please mention abdominal girth after or at or after 30 weeks of gestation only. Okay, so coming to symphysiofundal height, what is the importance of symphysiofundal height?
So if the head is engaged or not, will know, ma'am. So
okay. Yeah. So it is not important for the engagement basically. Symphysiofundal height again, it is importance is that it increases by 1 centimeter per week. after 24 weeks of gestation. So remember, this is after 24 weeks of gestation. Okay. So symphysiofundal height increases by 1 centimeter per every gestational week increase, and it corresponds to gestational age in weeks only up to 36 weeks. Okay, so it corresponds between 24 to 36 weeks. It corresponds to uterine height in centimeters to gestational age. Okay, so again, I'm telling you, don't measure symphysiofundal height before 24 weeks. Only 24 and above you measure the symphysiofundal height. Okay, that is when it corresponds to gestational age in weeks. Okay, after term, during term, when the patient, though it corresponds only up to 36 weeks, even when the patient comes at term 38 weeks, we usually write, because that time uterine height is 32 centimeter with there is a fullness in the flanks. So in the term also we calculate mainly for the calculation of estimated fetal weight. Okay, so you know that there is a Johnson's formula where we calculate the estimated fetal weight, right? So for calculating the estimated fetal weight, we take symphysiofundal height at term. Okay, so symphysiofundal height is important is because it corresponds to gestational age in weeks by centimeters after 24 weeks of gestation. That is important. And Leopold manuals, you have mentioned perfectly. There is no any mistake in that. And I want to tell you one thing. Manuals, all the Leopold manuals are the pelvic grips are done at 28 weeks and above. So before that, before 28 weeks, okay, it doesn't matter whatever is the lie of the fetus, because it will expel even if it is a transverse lie. So before 28 weeks, that is at 24 26 weeks, don't mention fundal grip, lateral grip, first pelvic grip and second pelvic grip. Don't mention any manures. The purpose of Leopold manures is you want to know what exactly is the lie of the fetus, what exactly is the presentation of the fetus, so that it is helpful for your obstetric management in the labor. And that will not help at 26 to 24 to 28, 26 weeks or before. So if the patient comes at 24 weeks, 26 weeks, you have to mention uterine height is by palpation 24, 26 weeks. Fetal parts are felt. You have to mention ballotment is present. Okay, so that is external ballotment is present. So that rules out basically molar pregnancy. Okay, so please don't write manures before 28 weeks. 28 weeks and above only you are going to write the all the manures. Before that you don't write any manures. Okay, correct. So abdominal girth and symphysiofundal height you have mentioned, it's perfect. So for period of gestation it is corresponding 98 centimeter. It is not actually over distended. So I think here it is the flanks are not full, right?
No, ma'am.
Yeah. So first thing you missed is uterine height is 36 weeks with fullness in the flanks. With flanks are not full. That sentence should come. So
Okay, ma'am.
that is important. Okay. One person has asked the doubt. Just 1 minute. Okay, we'll just clear up the doubts now only. Better, because again it will be late. Yes, so some people have answered correctly. It corresponds to gestational age in weeks. Symphysiofundal height. How do you calculate the Johnson's formula you are asking? So by Johnson's formula, how do you calculate this? Symphysiofundal height into 12 into 155 will give you fetal weight. It is given in your textbook, Datta. If the head is actually not engaged, then it is 12. If the head is engaged, you have to multiply by 11. Either 12 or 11, you have to multiply into 155. Will give you fetal weight in grams. Okay. Yeah. Next slide.
Auscultation. Fetal heart in the left spino-umbilical line, which is 140 beats per minute, and it is irregular in rhythm.
Okay, it's irregular.
Yes, ma'am.
Okay. So, what do you suspect if the fetal heart is irregular?
Normally, it is irregular.
Okay, so it is actually little difficult to pick up irregular rhythm by auscultation, because normally you have definitely beat to beat variability will be there in all the normal fetal heart rates. So it is not constantly 120, 130 like that. So it can vary between 120 to 160, which is normal. So rhythm can be picked up only by NST. By doing a cardiotochogram, you can make out very well. Okay. So if you write 140 per minute, that is enough. But obvious severe bradycardia, suddenly there is a bradycardia, suddenly there is a tachycardia, you can say it is irregular. If it's an obvious change, if the change is really obvious, generally it suggests that baby is having some congenital heart disease with some arrhythmia disorders. Okay, SVT like that. Even fetal arrhythmic disorders can happen. Only in those cases you can definitely make out there is a gross irregular heart rate. Otherwise, mild changes in the heart rate is normal because it's a normal beat to beat variability. Like there's a fetal movement, suddenly there is a slight increase, again it comes back to normal. So that is actually a normal thing to happen. But only if you feel there's a very gross irregular heartbeat is there, then you comment that it is a irregular. Okay. Otherwise, it is really actually difficult to make out by auscultation that it is completely irregular. Okay. And someone asked why to check for sinuses. Yeah. See, local rise of temperature, tenderness, we don't write. Okay. But you have written no local rise of temperature and non-tender, because basically as a I think as a standard method of teaching in surgery and medicine, you would have taught that on palpation, that is the first thing to be done. Okay, so there are some obstetricians who are very particular that you don't write local rise of temperature, tenderness, because we don't anticipate anything. You know that this distension is not a lump or a swelling, it's a pregnancy. It's quite obvious, but doesn't matter because there is always a difference in teaching from medical college to medical college. Doesn't matter. So as a part of standard examination, you have written that hernial orifices are normal and all. You have written sinuses or hernial orifices are free. Okay,
Yes.
it is not compulsory to write in an obstetric examination. I agree. No local rise of tenderness, temperature. We were not. We never wrote in our examination. But as a standard part of teaching, if you are writing, it is okay. These are minor differences. Okay, like even when you are writing head-to-toe examination, you have written vitals first. Like patient is afebrile, pulse, BP, like that. In some medical colleges, they tell that first thing you do write is like built on nourishment. Once you say that patient is moderately built, moderately nourished, then you mention first thing is height and weight, then followed by head to toe examination, pylorictus, everything, and head to toe examination itself will have breast, spine, thyroid. Then you measure the vitals. Vitals is in the end. So it doesn't matter. You have written vitals in the beginning, then followed by head to toe examination. There are some changes from teaching from medical college to medical college, but it is doesn't matter much. Okay, so you have written hernial orifices are normal and all, doesn't matter. It's okay. So local rise of temperature, tenderness is routinely written in the palpation findings in a surgery or a medicine case. So it's actually not applicable for obstetric case. So it doesn't matter. Okay, so even if you're writing, it's not a gross mistake or anything, doesn't matter. It's okay, you can write. Yeah, okay, and fetal heart rate irregular, you be really sure when you're mentioning irregular. Okay, so mild changes like 1 minute you count, sometimes there is slight increase in the heart rate, then it comes down to normal. It is okay. It is normal. It's a normal phenomena, bit to bit variability in a fetus. Okay, like if you see NST also, it is not always a standard line. Like what we see ECG, it is not like that. There is always a variability between 120 to 140, going up to 160 with the fetal movement. It is normal. But there is a gross bradycardia, then again suddenly going into tachycardia, which you can easily pick up with auscultation. Definitely it's an abnormal rhythm. Okay, it suggests that baby is having some congenital heart disease, or maybe it is a fetal arrhythmia disorders. Okay, yeah.
Okay.
Next slide.
Summary, no? 30 years old lady who is G.
Okay. Can you just give me 1 minute? Just 1 minute. I need. Give me 1 minute break.
Okay, ma'am.
Sorry for the disturbance. Please continue.
30 years old lady who is gravida 2 para 1, living 1, married since 6 years with no previous history of diabetes mellitus in preconception period, was found to have raised glucose levels during a regular antenatal checkup to the hospital with 18% of calorie deficit and positive family history for diabetes mellitus.
Yeah. So summary. You have one more slide for summary.
Provisional diagnosis.
Yeah, so summary always includes all the positive findings in the history and examination. So, and examination revealed a term uterus with a fetus corresponding to period of gestation in cephalic presentation. Okay, summary doesn't include, summary is not just for history. Summary of the case includes both for history and examination. So, but there are times when you are given a short case, they say, give me the summary of history. Like only that time you'll go, you'll give only summary of the history, then followed by detailed examination. But generally, if in the exam, like there are too many candidates, sometimes they want to finish off early. They'll ask you summary of the case. Then you have to give summary of both history and examination.
Ma'am, but I've mentioned that provisional diagnosis, ma'am. The presentation.
Diagnosis is different. Diagnosis is different. Sometimes they directly ask you what is your diagnosis. So that time you give diagnosis. Okay, but when you're asked for the summary, you write both summary of history and examination findings. Like if it's a case of anemia, you write that. I mean, all the history, your summary of the history. Then examination revealed that she has severe pallor with a small baby or with a probably a small for gestational age baby in cephalic presentation. So that also will come in your summary, everything. Okay. Okay. Next, we'll move on to the diagnosis.
Yep. 30 years old lady, womb 68 kgs, was gravida 2 para 1, present with single live fetus in longitudinal live with cephalic presentation at 37 weeks of gestation, and elevated blood glucose levels detected first time in pregnancy during a regular antenatal visit, and no previous history of diabetes mellitus suggestive of gestational diabetes mellitus.
Okay. So provisional history, you don't write previous history of GDM. It was not there and had elevated blood glucose levels. It is your diagnosis. So elevated blood glucose level is not your diagnosis. You know that it is GDM now, right? This is a case of gestational diabetes mellitus. Okay. So you have to, one thing is in your diagnosis, you have to mention the age, obstetric index, then comes the gestational age first. So presentation will come later. So first is age, obstetric index, period of gestation. Then you mention the fetus in cephalic presentation and all that with GDM. Okay, with GDM. And if you think already like patient is admitted for 1 day on insulin with GDM on insulin, or she has not yet been started on insulin, she is only on diet and exercise on MNT, medical nutrition therapy. That will be your diagnosis. So diagnosis will not contain had elevated blood sugar, weight of 68 kgs, and no previous history of diabetes mellitus, regular ANC. All this will not come in your diagnosis. They all come under your case summary. Okay, so case summary, you can include all the important positive and important significant negative history. But in the diagnosis, you have to mention that she is a 30-year-old second gravida para 1 living one with 37 weeks of gestation with cephalic presentation with GDM on insulin, or I think at 37 weeks definitely would have started on insulin. Okay, so with 37 weeks of period of gestation on insulin, or if any time in the earlier pregnancy with 28 weeks of period of gestation on medical nutrition therapy on MNT. So this is your diagnosis. Yeah. So someone has asked whether to be include in labor or not. Definitely you will include whether the patient is in labor or not when the patient comes at term pregnancies. All the term pregnancies you have to write in labor or not in labor. Okay. So here otherwise for all the preterm cases, no need to write for everyone in labor, not in labor, unless patient comes with pain abdomen or leaking PV. Okay. Like patient is at 32 weeks of period of gestation, has come with pain abdomen. That time you write in labor, not in labor. Okay, so or otherwise in labor, not in labor, we comment only at term and beyond in the diagnosis. Okay, like in this case, 30 years, second gravida para 1 living one with 37 weeks of gestation in cephalic presentation. So cephalic presentation itself means that it is a longitudinal lie. You need not comment separately that it is a longitudinal lie. Cephalic and breech itself says that it is a longitudinal lie. Okay, so 30 years, second gravida para 1 living one with 37 weeks of gestation with in cephalic presentation with GDM on insulin, not in labor, because here it is 37 weeks completed. So it is a term gestation. Here you will include not in labor. Okay, so otherwise for preterm cases less than 37 weeks, no need to routinely write it as a in labor, not in labor, need not be written unless patient has come with the signs and symptoms of labor, like she has come with pain abdomen, or she has come with bleeding per vagina, or she has come with leaking per vagina. In those cases, again, you palpate the uterus when you're telling uterine height. Uterine height is 36 weeks. Uterus is relaxed, or uterine height is 36 weeks with contractions present. That time you have to write here that she is in labor. Okay, generally you will not do PV exam. Pelvic examination is not done by undergraduates in the examination. So by contractions, you can make out by palpation. And here you can write in labor, not in labor. Okay, so any doubts till now? Okay, someone, anything else? Yeah, so yeah, that's it. So we'll go on to the next slide.
Ma'am, I've not.
Yeah, okay, fine. So investigations, so now how do you manage this case? So this patient is admitted in your hospital now. How will you manage your case?
First, investigations, ma'am.
Yes.
Once the patient comes to the hospital, first routine investigations are done, like blood grouping, RS typing, BDRL, HIV, HbSAg, urine culture and routine tests are done. Then, especially for this case,
Okay.
doing
Okay. Let me be very clear. What are the routine investigations in pregnancy? List it out now. Start now. Again. Routine investigations in pregnancy.
blood grouping, RH typing,
Yes.
hemoglobin, hematocrit,
Yes.
Cervical cytology, VDRL.
It is okay. Cervical cytology not routine in India. We have not yet started doing it. It's recommended in UK, US RCOG guidelines. Okay. Then
VDRL, HIV, HbSAg, then urine routine and culture.
okay. Culture is not routine again. Only for the patients like anemia cases, GDM cases, you do urine culture. Not routine. It is not a routine.
Okay,
Anything else important you have missed now in a GDM case?
blood sugar in urine. That
Screening test for GDM.
blood
Okay.
sugar.
So for Indian guidelines, the routine investigations in pregnancy as recommended by WHO and for Indian guidelines is one is hemoglobin, urine routine for protein sugar microscopy, serum VDRL, HbSAg, HIV, screening test for GDM, that is GTT, glucose tolerance test, and blood grouping and RH typing. So these are the routine investigations in pregnancy. Serum TSH is not recommended by WHO. Thyroid profile is not recommended by WHO, World Health Organization. But so it is not compulsory to do in a PHC setup, but wherever you have facilities available. Okay, like in a medical college, being in a medical college, we have facilities to get a thyroid profile. So we are routinely doing thyroid profile for everyone. So Endocrinology Society advocates that you do thyroid profile in all the pregnant women, but there is no recommendation by the WHO or Government of India for pregnant women. And again, pap smear, it is not recommended again by the Government of India. And HbA1c is we don't do as a screening test yet. So the screening test for gestational diabetes mellitus routinely, universally for all the pregnant women in India is actually a DIPSI test or a one-step GTT test. Okay, so coming to specific investigations in your case, what are the specific investigations in your case?
GTT, then the 7-value blood sugar profile has to be done once we start around diabetic diet.
Okay.
Then
you wanted to rule out infections, right? So urine culture sensitivity for her. Urine culture sensitivity, you will get it done. Then
serology for ruling out other infection.
okay.
Then fundoscopy.
Yes, good. Fundoscopy is important. Okay. So here, specific investigations, you don't need much except for blood sugar monitoring and urine for ketone bodies. So we routinely check if there is any patient has gone in for ketoacidosis because of the stress, or if she, particularly if they're in labor, you have to check for the urine for ketone bodies. Generally, we do only blood sugar monitoring. And for GDM cases, thyroid profile is a must. Okay, for all the pregnant women, it is not must because there can be multiple endocrinopathies can coexist. For all the GDM cases, you have to get thyroid profile, blood sugar monitoring. And glycosylated hemoglobin is not important in your case because she's already term. She's already 37 weeks. So HbA1c is not required at this period of gestation. But if she were to be diagnosed in the first visit, or she were to be diagnosed in the 24 weeks, had have got a glycosylated hemoglobin, basically it will not change your management as such. But only thing is, it's important for us to counsel regarding congenital malformation risk. Okay. That is why you get a glycosylated hemoglobin at the earlier period of gestation. At 37 weeks, now she's diagnosed to be GDM. Now HbA1c doesn't have any role for her. Okay. And other investigations can include urine culture sensitivity. If the patient has got vaginal discharge, you can get a vaginal swab testing done to know whether she has got any yeast infections or any of those. That can be done. And urine for ketone bodies. These are optional. And fundoscopy also we can get it done to see if there is any fundal changes because of over diabetes. Okay, may not be in a GDM case, not the first time diagnosis at term. It may not be there. Okay. Okay. So now how will you manage her treatment part?
First, we have to start on diabetic, that is medical nutrition therapy and exercise. So the
Okay.
medical nutrition therapy, which recommends that 40 to 50% of carbohydrates of total calories and 20% of proteins, 25% of fat. In that, less than 10% of saturated fat will be present of the total calories.
Okay.
Then, according to our BMI, for a 30 kilocalories per kg per day is recommended. So we advise her
Sorry.
to take.
Sorry, repeat again. Come again.
According to our pre-pregnancy BMI, our calorie intake should be around 30 kilocalories per kg per day. We recommend that. So along with that advice, he is asked to take 3 major meals plus 3 minor meals or frequent short small meals.
Yes. Yes.
Then exercise, moderate exercises are recommended.
Okay.
Moderate exercises like brisk walking or upper limb exercises. Then after that, sugar charting is done after 15 days or 3 days if she is in term.
Okay.
Then if it is not controlled or the values are not coming below the metabolic goals, like the fasting blood glucose level should be between 70 to 90, and 1 hour pp should be less than 140 mg per dl, 2 hour pp should be less than 120 mg per dl. If these are not achieved, then after 2 weeks we start her on insulin therapy.
Okay.
So insulin, um, 3 to 4 daily injections of regular insulin and intermittent insulin, that is isophane, can be given.
Okay. Long acting isoprene. Okay.
Um, Usually the oral hypoglycemic drugs are contraindicated, but there are only 2 drugs which can be given in pregnancy, that is metformin and glyburide.
Okay. So when you're telling management is actually mean particular to your case. Okay. So whatever you said is perfect. So the first line of management whenever you diagnose GDM, gestational diabetes mellitus, is actually medical nutrition therapy. So medical nutrition therapy, MNT, consists of diet and exercise. Diet, it's just make it just to be simplified, 50% carbohydrate, 25% protein, 25% fat. There is a range, 20 to 30 is the fat and 15 to 25 is the fat actually. But still it is just to simplify, 50% should be carbohydrate, 25% should be protein, 25% should be fat. And you always ask her to split the meal and tell her not to take a heavy meal. Okay. And when
Yes.
you're advising regarding diet, it's always important to keep their socioeconomic status and their cultural background and tell them. Like earlier, what she was eating. Okay, if it is idlis, okay, if it's a small size idli, she can only take 3 idlis at a time, not more than that. Okay, if it's a little bigger idli, it's only 2 idli at a time. And in the afternoon also, like she can take, if it's small chapatis, it is only 2 chapatis with vegetable. Okay. And what you mean by snack is even 1 cup of milk is a snack. Even 1 apple or 1 banana is 1 snack. So only 1 fruit will be taken as 1 snack. So if you say that she can take 3 snacks, 3 meals, she'll be actually end up eating more. So it has to be clearly, you have to mention that keeping whatever food she is taking. Okay, so that should be kept in mind. Ask her to split up the meals and tell her not to take too much of food at a time, so that blood sugars there is no sudden peak in the blood sugars, they are uniformly maintained. And snack means again they'll end up start having milk with biscuits and all that. So tell them biscuits are not allowed. She can take only 1 cup of milk, or only 1 fruit will be taken as 1 snack. Okay, it's usually preferably the fruits allowed are actually banana is allowed, though it is a high glycemic index, but she can take only 1 small elaki balenu. We say no, that small banana she can take, or 1 apple, or 1 pear she can take, or 1 orange. Okay, oranges are definitely better. Orange, strawberry, and these are actually apple, pear. They're actually low glycemic index fruits, so she can take that. And vegetables, boiled vegetables, sprout she can take. And even 1 egg is considered as 1 snack. So whenever she want, it's better she has a good protein intake is very important for her. So she can take 1 egg per day if she's a non-vegetarian. If she is a vegetarian, she has to take small cup of sprouted pulses instead of egg. So but that will be considered as 1 snack. So that has to be clearly mentioned. And exercises, moderate exercises, like patients who are already doing household work and all, they can continue to do their household work, and they can do at least 20 minutes of walking. People who have never used to any exercise better, best thing for them to advise is walking. Okay, so walking is the best exercise. They can do slightly brisk walking, but see to it that nearing term they don't lose their balance. So it's always better they take someone as their accompaniment. They're doing the exercises. In the earlier pregnancies, if they are coming, you can start with you can teach them the upper body exercises, or even if they want to do any other sitting and any other exercises, they can do it in the sitting position or with the wall support, so that they don't lose their balance and they don't fall. That is important. Okay, and as you said, it's the recommended therapy is 2 weeks of medical nutrition therapy. After 2 weeks of MNT, you get a fasting blood sugar and a PPBS, postprandial blood sugar. If PPBS is 2-hour value, 2-hour postprandial blood sugar is more than 120, then she has to go for additional medications. Most of the GDM, almost 90% of the gestational diabetes women, GDM women, maintain their blood sugar less than 120 with the MNT. So MNT is definitely a very good medication. Standard diet and exercise. Okay, if they follow properly for 2 weeks, they need not start any drugs. So after 2 weeks of medical nutrition therapy, irrespective of the blood sugar values, like even up to 200, even up to 180, they can usually start with the medical nutrition therapy. So after MNT, 2 weeks of MNT, if her PPBS value is more than 120, it's an indication to start additional drugs. Okay, the standard way of management is actually starting with the insulin. But now Government of India, both FOXI and Government of India have approved use of metformin during pregnancy. Okay, so metformin is approved for use in pregnancy. Both metformin and insulin, both of them come under category B. So they have the same risk. So both of them can be used in pregnancy without any additional adverse effects. There is many long-term trials even with the metformin used during pregnancy. Babies have been followed up, so it is indicated in pregnancy. It can be used. Okay, and you said even glyburide also can be used. Okay, but now standard as of now, the recommended therapy by the Government of India for GDM is metformin or insulin. Okay, so this is a standard management. Okay, but you start insulin. When you start insulin is one is after 2 weeks of MNT uncontrolled. Second indication for starting insulin or OHA is when you are diagnosing GDM for the first time at term. That time you will not wait for 2 weeks of MNT, because you know that the fetal weight gain is very rapid in the last 4 weeks of pregnancy. She is more prone for GD, more prone for macrosomia now. Okay, so you have to start insulin for this lady. This lady, because she's 37 weeks, will not wait for 2 weeks of MNT for her. Okay, So indication for starting oral hypoglycemic or insulin is, one is after 2 weeks of MNT, her blood sugars are uncontrolled. Second indication for starting insulin therapy is for the first time it is diagnosed at the 3rd trimester test. That time directly you will start with the insulin. So you're starting insulin or OHA doesn't mean that you forget about MNT. So it is MNT plus metformin, MNT plus insulin. Okay, so for 3rd trimester diagnosed patients, we will start with medical nutrition therapy and oral hypoglycemic agent, or we will start with medical nutrition therapy and insulin. Okay, and third indication for starting directly the medical management is the blood sugar is when the fasting blood sugar is more than 120 and ppbs is more than 200 in the initial test. So when the gtt is more than 200 in the initially, okay, in those cases, that is when it is you're suspecting that it is over diabetes. In those cases you can start insulin therapy directly. So these are the indications for starting insulin. Okay, standard is, as you mentioned, yes, 2 weeks of MNT uncontrolled, you go for the insulin management. Okay, but there are times you start directly insulin. That is when the patient is diagnosed for the first time at 3rd trimester. Or other thing is when the patient's GTT values are suggestive of over diabetes. That is when the blood sugars are more than 200. In those cases, you directly start with the insulin because there is a more risk of having macrosomia baby later. Okay, that is the reason you usually start insulin earlier. Okay, and the standard recommended insulin is actually, now it is a combination of a short acting and a intermediate acting insulin, that is 30-70 preparation of a mixed injection. Okay, you have heard mixed injection, no? So earlier we were giving regular insulin, now we are giving mixed injection. Okay, so 30-70 preparation of a mixed is usually started in the morning. Okay, if additional, and you keep on monitoring her blood sugar once in 3 days. So you admit the patient, start with the insulin therapy. So in your case, what you are going to do is you should admit the patient, start doing your blood sugar charting, and start with the insulin treatment. Okay, so start with the insulin treatment. So you keep on monitoring her blood sugars once in 3 days. So once in 3 days, if the FBS is high, you have to increase the night dose of insulin. If the ppbs is higher, you have to increase the morning dose of insulin. So you have to titrate the insulin dose, then you can discharge her. Okay, so any other investigations you want to do? So you said blood sugar monitoring and then starting with the insulin. Anything else? Fetal investigations you want to do? Any other fetal test you want to do?
Fetal monitoring,
Yes.
daily fetal movement count,
Okay.
then NSP, biophysical score.
Yeah. Okay.
Then USG level 2 can also be done.
Ultrasound, yes. Okay, so because it is a gestational diabetes mellitus, it is a high risk pregnancy, it is an indication to start a CTG monitoring. Okay, our NST testing has to be done. For all the low risk pregnancies, you recommend only daily fetal movement counting. That is, DFMC is recommended for all the low risk pregnancies. For high risk pregnancy, along with DFMC, you start doing even NST, non-stress test, has to be done twice a week. For this case, you will be doing NST twice a week, and then you will be doing an ultrasound. Okay, so biophysical profile is not compulsory unless you have some other indication, like it is GDM combined with preeclampsia. Our baby has got some other problem, like it's a quite macrosomia baby. In that case, you may have to do even biophysical profile. Our patient is having reduced fetal movement. Okay, otherwise you have to do an ultrasound for her. So what all things you want to note in the ultrasound? Okay, one person has asked whether renal function tests are routinely done. RFT is not done for GDM cases, but if you think it is a over diabetes, it has to be done. For over diabetes, routinely you have to do a renal function test, but GDM cases, RFT is not compulsory. It's not routinely done. Okay, yeah. So ultrasound, what all things you will look for in ultrasound?
Amniotic fluid.
Yes, good.
Then
You will confirm the presentation. So you already know that it is cephalic presentation, but sometimes you always want to confirm because palpation is specific only around 60 to 70% of the time. Sometimes you will think it is cephalic, but in the scan it might come as breech. Okay, so you will confirm your findings. That is presentation you will confirm. You look for any liquor abnormalities. So what liquor abnormality you are expecting here? In GDM, what will be the amniotic fluid abnormalities expected? It will be less or more?
It will be more, ma'am.
Yeah. So polyhydramnias. So you want to rule out polyhydramnias here. Yes. Then you will do fetal parameters to rule out to know estimated fetal weight. Okay. So fetal biometry is done. Fetal biometry is done basically to look for the specifically abdominal circumference and the estimated fetal weight. Abdominal circumference is the first indicator to tell you that it is a big baby. That's the first thing to increase. If the abdominal circumference is more compared to other parameters, like abdominal circumference is corresponding to 36 weeks, whereas all the other parameters are corresponding to 32 weeks, it is going to be a macrosomic baby. Okay, so you will look for specifically abdominal circumference and all the other parameters also measured basically to know the estimated fetal weight. Okay, because macrosomia is a known complication, right? Okay, why do you think there is a macrosomia and polyhydramnias in GDM? What is the reason?
There will be fetal hypoglycemia. Because of that, there will be increased insulin in the fetus. So, in insulin is the growth. It is basically in the growth of the fetus, insulin is more important. So there will be increased weight of the fetus.
Yes. Okay, then why polyhydramnias?
There will be here. There will be polyuria. So in the fetus, there will be polyuria because of hyperglycemia. So there will be polyhydramnias.
Okay, yes, you're right. So one is macrosomia. The reason why there is a macrosomia is the reason is there is a maternal hyperglycemia. So there is fetal hyperglycemia leading to fetal hyperinsulinemia. So hyperinsulinemia leads to increase in the IGF-1 and 2. Insulin-like growth factor 1 and 2 are increased in the fetus. So there is excess somatic growth of the baby leading to macrosomia. Okay. So polyhydramnias, yes, that is one more reason is because hyperglycemia leading to polyuria in the baby, leading to polyhydramnias, and excess glucose induced osmosis. Yes, correct, perfect. There is a because polyuria has got again glycosuria is there from the baby. So there is excess irritation of the amniotic membrane leading to excess secretion by the amniotic membrane itself leading to polyuria. The other reason for polyuria is associated polyhydramnias is associated any defects, any neural tube defects or anything. Okay, so these are the causes for polyhydramnias. Okay, so you have heard of Pedersen's hypothesis?
No.
Okay. So Pedersen's hypothesis is the same. What you mentioned, the theory for macrosomia. Okay, so macrosomia is because of excess insulin-like growth factors in the baby, leading to shoulder dystocia. Okay, so that is called as Pedersen's hypothesis. Okay, so there are two hypotheses you may have to remember in GDM. One is Pedersen's hypothesis. Okay, Pederson. Pedersen's hypothesis basically says that it is there is a macrosomia. What the reason for macrosomia leading on to shoulder dystocia? That is called as Pedersen's hypothesis. The other hypothesis is Barker's hypothesis. You have heard of Barker's hypothesis? So Barker's hypothesis is all the adulthood diseases actually start in the intrauterine life. Like this baby, because it's being in the GDM mother, later when it becomes an adult, it is more prone for all the metabolic syndrome diseases like obesity, diabetes, hypertension, cardiovascular disease. That is Barker's hypothesis. So keeping these two in mind, you have to manage the cases. Okay, if the mother is continuously having high blood sugar, fetus is also at risk, not only the short term, also the long term complications. So that is Barker's hypothesis. Okay, so can you tell me what are the complications, fetal complication, both maternal and fetal complications in a GDM mother?
Maternal complications,
Yes.
miscarriage, labor, premature rupture of membranes, the infection, polyhydramnios.
Okay.
Then we'll have increased incidence of preeclampsia, then and distress. Then other complications of diabetes like retinopathy, nephropathy, neuropathy.
Okay.
Then fetal complications, I'll tell you.
Okay.
Fetal complications like macrosomia, shoulder dystocia, then IUGR, intrauterine death of the fetus.
Okay.
Then neonatal
IUGR is not common, no? Okay.
IUGR. Then neonatal complications because of prematurity there will be respiratory distress syndrome.
Yes.
Then hypokalemia, hypoglycemia, hypomagnesemia, hypocalcemia. Then hyperbilirubinemia will be there, and polycythemia.
Okay. Anything intrapartum? Complications intrapartum?
Prolongation of labor.
Okay. Okay. Yeah, give me a minute. Just
Yes, ma'am.
So complications, maternal complications include mainly, we'll start with the early pregnancy. So diabetes mellitus gestational, maybe it can be diagnosed even earlier also. It can be there, okay? Or it could be over diabetes. Purely GDM doesn't have much complications. Like because pure gestational diabetes mellitus, all the impaired glucose abnormalities generally start later by 24, 28 weeks. So pure gestational diabetes mellitus may not have much of the maternal complications. Only in labor could be because of macrosomia. Okay, but if they're over diabetes and all that, one is it could be actually even recurrent abortions. Okay, like patient is having over diabetes, there can be early pregnancy losses. Second thing is it can lead to preterm labor. Okay, so preterm labor, one reason is either it could be over distended abdomen, okay, or it could be related to infections, like patient is having UTI, or it could be vaginal infections leading to preterm labor. So pregnancy failure, early pregnancy failures can happen, preterm labors can happen, and PROM leading to secondary infections is common. Okay, and the main complications are actually related to the genital tract trauma during intrapartum. So when you're delivering a bigger baby, it can lead to any trauma into the genital tract. Okay, perineal injuries are more common, and postpartum hemorrhage (PPH) is more common in the mothers with the diabetes. So coming to fetal complications, it could be again fetal complications in the fetal complications mainly, or it could be intrapartum complications, or again neonatal complications. So fetal complications during the antenatal period can include, one is fetal malformations. Okay. So when you're when you're telling that when you're saying fetal malformations are more, it is important you mention fetal malformations. Don't say chromosomal abnormalities are more. I think when you mention family history, you have written no history of chromosomal abnormalities. You never know what is a chromosomal abnormality. It is difficult to make out. Okay. So you have to mention no history of any congenital malformations in the family. Same thing here. Okay. Diabetes doesn't increase chromosomal abnormalities. It increases congenital malformations. Okay. So there is an increase in the congenital malformation risk with the babies being born to the diabetic mother. Okay, that is an important thing. There can be sudden IUDs or sudden stillbirths are common in the antenatal period, and intrapartum period mainly it could be related to the macrosomia, difficult labor, and you also mentioned RDS, yes, and difficult labor, difficult labor, there can be shoulder dystocia leading to nerve injuries. Okay, brachial plexus injury, Erb's palsy, they can happen during the intrapartum period. And postpartum neonatal complications include sometimes baby will have more risk of having respiratory distress syndrome compared to the same babies of the gestational age. Same gestation compared to the same gestational age weight babies compared to them, GDM babies have got actually more risk of RDS, respiratory distress syndrome. Okay, and other thing is there can be sudden hypoglycemia episodes. Okay, hyperbilirubinemia episodes like that. Okay, so can you tell me why? What are the important fetal malformations which happen with the babies to the babies of the GDM mothers?
VSC, aneurysm,
Yeah.
caudal regression,
Yes. Yes.
then hypertrophic obstructive
Yes.
cardiomyopathy.
Yeah, so all the organs can be affected. The commonest is actually neural tube defect still. The commonest type of malformation even in the general population is neural tube defect. Here also the commonest type of malformation, fetal malformation in the babies born to GDM mothers is neural tube defects. Okay, more specific type of anomaly will be caudal regression syndrome or sacrococcygeal teratoma. Specific to GDM is actually caudal regression, but more common is still neural tube defects. Okay, so in the general population, it's around 2 to 3%. Whereas babies born to GDM, the risk of malformations is increased up to 8 to 10%. So it is more. So fetal malformation risk is very high. Okay, that is why we get a glycosylated hemoglobin whenever we have diagnosed GDM in the earlier period of gestation. If the HbA1c, glycosylated hemoglobin, is more than what is the cutoff?
0.5.
Okay, the HbA1c is more than 10. The risk of malformation is very high. Okay, compared to the risk of malformation when it is 7 and 8. So when the HbA1c is only around 7 to 8, the risk of fetal malformation like neural tube defect is only around 3 to 4%. Whereas if it becomes HbA1c is more than 10, the risk of having a neural tube defect is almost 25%. Okay. So when the glycosylated hemoglobin is more than 10, it's easy for us to tell we have to counsel the mother that she has to compulsorily get a anomaly scan. We have to look for the specific defects like that. After neural tube defect, the second commonest, almost equal, is actually cardiac malformation. VSD and TGA, transposition of great vessels. These are the common malformations. Even other renal and other malformations, skeletal and other malformations also can be seen. But cardiac and neural tube defects are the commonest type of malformations. Okay, so the reason why there is increased malformation is again because of hyperglycemia induced free oxygen radical injury. That is the reason why there is an increased malformation. Okay, so macrosomia, we understood why there is a macrosomia. So what is the reason for excess more stillbirths or sudden IUDs? We also call it as unexplained IUD. You know what is unexplained IUD? Okay, so what is the reason for increasing stillbirths in the mothers with gestational diabetes mellitus?
I don't know.
Okay, so we already understood the Pedersen's theory that it is hyperglycemia and hyperinsulinemia. So hyperglycemia and hyperinsulinemia increase the oxygen demand in the baby. It's mainly somatic growth, skeletal growth. So there is a increased oxygen demand leading to hypoxia in the baby. Okay, so it's basically because of macrosomia and hyperinsulinemia induced hypoxia in the baby. That is the one reason why there is a increased stillbirth risk. Okay, so if you maintain blood sugars very well, like there is no hyperinsulinemia episodes in the baby, then the risk of stillbirths actually reduce. If there is no macrosomia, the risk of sudden stillbirths are little lesser. Okay, so someone has commented that it could be because of maternal hypoglycemia. Yes, hypoglycemia is more dangerous than the hyperglycemia. It can result, but most of the time the reason is actually because of hyperglycemia leading to hyperinsulinemia, leading to excess skeletal growth, somatic growth. leading to more oxygen demand and hypoxia and ketoacidosis in the baby. That is the reason for the stillbirths. Okay, so that is one of the reason why the stillbirth risk is increased. So we call it as unexplained. We say unexplained stillbirths are common in GDM. The reason why we say unexplained is most of the stillbirths are usually they have a meconium staining liquor, or they have got IUGR, or they have some features of placental insufficiency, that is small placenta, calcific placenta, like preeclampsia, like that. So here you don't have any features. Baby is a good weight baby with a good amniotic fluid, without any meconium staining, without any placental insufficiency features. It apparently is completely normal to grossly to look at. That's why we call it as unexplained IUD, unexplained stillbirths. Okay, they are quite common in the pregnant mothers. That is why, but it is compulsory to do a biophysical profile and NST in a mother with a GDM. So all the GDM mothers after 32 weeks. So once they cross 32 weeks, you have to do fetal surveillance test additional to DFMC. So we routinely do only daily fetal movement count. But GDM mothers, you have to do NST test also. After 32 weeks of gestation, every once in a week, they have to get a CTG monitoring. And once in 4 weeks, 3 to 4 weeks, they'll be getting a scanning done for the looking for the growth and any fetal abnormalities. So fetal surveillance tests are more important in the GDM. Okay, so what is the what is the reason for increased RDS? Why there is RDS is risk is increased in the babies being born to GDM?
Because of insulin will be increased in the fetus. So
Yes.
this insulin will inhibit the production of um, for, the surfactants which is required for um, the surfactants will be reduced because of that. So they'll have increased risk of RDS.
Yes, good. So hyperinsulinemia basically reduces the cortisol levels. So cortisol is it's actually a precursor for synthesis of surfactant. Okay, so there is a reduced cortisol levels. So there is a reduced surfactant. So there is a increased RDS risk. Okay, so and after shall we discuss the intrapartum management?
Yes, ma'am.
Yeah. So how do you manage if this patient goes into labor? Okay, Ash has not gone into labor. How do you manage at 39 weeks now? So first, let us discuss when do we terminate the pregnancy in GDM mothers? What is the period of gestation when you are planning to terminate? You want to end the or you're planning for a delivery, vaginal delivery in GDM mothers.
So if we are managing it on diet, so we can wait till the term like 39 to 40 weeks.
Yes.
We have managed the GDM on insulin therapy, then 30, 38 plus 6 days to 39. I mean 38 weeks to 39 weeks we can wait. Then if it is over diabetes, then 37 to 38 weeks will terminate the pregnancy.
Yes. Okay. Very good. So whenever a patient has actually she's managed only on medical nutrition therapy throughout, you can wait till her expected date of delivery. That is 40 weeks. We can wait. Okay. And as you said, when the patients are insulin or on OHA drugs, we can terminate the pregnancy by 38 weeks. We terminate the pregnancy. And when she has got any other complication, like she's a case of diabetes with preeclampsia, and she has got some vasculopathy, in those cases, better to terminate early. Okay. Or when the patient has got history of previous GDM with stillbirths. Okay, so keeping all those things in mind, like patient had previously GDM with stillbirths at term 36 weeks, 37 weeks, she had stillbirths earlier. So keeping all those things in mind, you may have to terminate earlier. Okay, between 34 to 36 weeks, you may have to terminate depending upon her Doppler findings. Okay, yeah.
Yes.
So that is correct. So then, can we do induction of labor?
If if she is on diet, if the GDM is on diet, we can wait for spontaneous delivery. But if we are controlled on insulin, then we can do in induction.
Okay, induction will not depend whether she is on MNT or whether she is on insulin.
Or
Okay,
if she
depends
has
upon her Bishop score. Induction will always depend upon the Bishop score. If the patient has come in spontaneous labor, when the Bishop score is more than 7, definitely no need of induction. Okay, so induction can be required in both the cases. Like patient is on MNT at 40 weeks of gestation, she comes with unfavorable cervix, you have to do induction. Okay, or if the patient is on insulin at 38 weeks, but cervix is completely unfavorable, you have to do induction. So induction of labor will depend upon the Bishop score, right? So induction, what I want to ask you is, induction is contraindicated or not? So there is no contraindication for induction. So no induction of labor is not contraindicated in GDM case or in over diabetes. Both PGE2 gel, that is Saviprime gel, what we call it as prostaglandin E2 gel. Okay, dinoprostone gel can be instilled. Even mechanical method of induction like Foley's catheter can also be done with no increase in the risk of infection in GDM. It can be done. So both mechanical and chemical methods of induction can be done. They are not contraindicated. Okay. So what are the precautions you take for induction of labor, and how do you manage when the patient is in labor?
When she's in labor.
Okay, now the patient is in labor. What precautions you will take, and how do you manage her in labor?
Okay, before that we have to see the fasting blood sugars and serum electrolytes, ma'am.
Okay.
Then once she is in labor, uh, then we'll start with the IV drip, giving fluids, dextrose like 5% dextrose. Then along with that, we have to set up insulin also, infusion.
Yes.
Then every hourly we have to monitor the glucose
Yes.
levels.
Good. Yes. Good. Then.
Then epidural anesthesia can be given for the pain relief.
Okay.
Then if the labor doesn't occur within 6 to 8 hours, then we can go for C-section.
Sorry, then we can go for
C-section, cesarean section.
okay. So yeah, someone has asked us for CPD. So when you're planning for labor, you're doing induction. We assume that CPD has been ruled out. Okay. So, but if there is a CPD, it's an indication for cesarean section directly. You will not do induction. Okay. So there are few cases of GDM where you directly take for cesarean section. They're mainly obstetric indications. Like there is a any CPD is there, or you feel that baby is too big. So macrosomia is actually more than 4 kg baby. By standard worldwide definition, it is more than 4.5 kg is macrosomia. But for Indian babies, the cutoff is actually 3.96, so approximately 4 kg. For Indian babies, when the estimated fetal weight is more than 4, it is an indication to do cesarean section directly. You will definitely not wait for labor in those cases. So for normal labor, where you have ruled out CPD, where you have ruled out macrosomia, you are planning, if the patient has come in labor, induction is not done, of course. But if the patient has not come into labor, she is already 38 weeks completed on insulin. She is MNT who has completed 40 weeks. You will assess the Bishop score. You will do induction of labor. So the precautions, what has to be taken is, you will get a baseline urine for ketone bodies, serum electrolytes, and blood sugars has to be done. And if the patient is on oral hypoglycemic or insulin, you have to skip the dose of oral hypoglycemic or insulin on the day of induction. So when you're planning for induction, that day she should not take any drugs, or insulin should not be taken. And if she is on MNT, no problem. Okay. So you have to skip the dose of the insulin or oral hypoglycemic. And as you said, yes, we have to start with the IV fluid drip. So IV fluid with insulin. That is, you start with a 5% dextrose solution with 10 units insulin has to be started for those patients. And what you do is, you have to do a hourly blood sugar monitoring. So every hour you keep on checking her blood sugars, and once in 4 to 6 hours you also check for urine for ketone bodies. So you have a keto sticks with a dip method, you can check for the urine for ketone bodies. So these two things has to be monitored during labor. Blood sugar values and urine ketone bodies has to be monitored throughout the labor, because labor itself is a stress factor for ketoacidosis. Okay. And GDM mothers, it's indicated to start with a prophylactic antibiotic. Okay, so generally for all the labors, you don't give prophylactic antibiotic. Only if they have episiotomy, you give treatment later, antibiotic. For GDM mothers, because they're at risk of increased infections, repeated pelvic examinations can happen, there can be more interventions later, you give prophylactic antibiotic in the beginning itself in these patients. Okay, so and once they enter active labor, you have to maintain partogram. Okay, so whenever, any case, whenever you take, either it could be cardiac disease, whether you take preeclampsia or anything. So whenever they ask intrapartum management, never forget partogram and AMTSL, active management of third stage of labor. These two are standard answers in all the labors. Okay, but specifically for GDM, what you are doing, that you mention first. Then once they enter active labor, so after that, start partographic assessment and labor is conducted. You have to watch for shoulder dystocia. Okay, then after the delivery of the baby, you have to do active management of third stage of the labor. Then the baby will be handed over to the pediatrician to monitor for the fetal complications, because it is more prone for hypoglycemia and other complications. Okay, so this is how you tell the labor management. So when you're telling the intrapartum management, specific management as per the case, but also remember, induction is dependent on the Bishop score. Never forget Bishop score. Never forget partogram. That is, once the active labor starts, partogram, you don't forget partogram. And once the labor starts after the delivery of the baby, never forget AMTSL, active management of third stage of labor. All the three should be kept in mind. This is compulsory when you're telling the intrapartum management. Okay, so same thing is followed here also. Okay, so generally we do, you have you know what are the components of active management of third stage of labor?
Yes, ma'am.
Yes.
You have to administer uterosonic agents, then delayed cord clamping has to be done, and the delivery of placenta has to be done by cord traction.
Control cord traction. Yes. Okay, so very good. So first thing is you have to administer the uterotonic, but important is administration of uterotonic. Timing is important, within 1 minute of the birth of the baby. Okay, so injection oxytocin 10 units IM is given within 1 minute of the birth of the baby. Second thing is delayed cord clamping. You wait for at least 1 minute or the cord pulsation stop. Then you clamp the cord, cut it. Then followed by controlled cord traction to remove the placenta. Yes, these three are the actually components of the active AMTSL. Okay, another important is massage, uterine massage. So we remember it as OCM. O is for oxytocin, C is for control contraction, M is for massage, uterine massage. Okay, so these three are the components. Okay, you do, but here in GDM, if the baby is macrosomic, you will do early cord clamping. That is the only difference. So routinely you follow active management of third stage of labor for all the babies with the GDM. But if the baby is macrosomic, you will do early cord clamping. Okay. Otherwise, you routinely do even delayed cord clamping even for the well-controlled GDM babies. Okay. So what are the neonatal complications you said? One is hypoglycemia. Can you tell me what is the reason for hypoglycemia in the baby?
The fetus will already have increased insulin levels. So once it is delivered, the hyperglycemia will come down. That is, the glucose which is coming from the mother will reduce.
Yes.
So the insulin is already more, so it will hyperglycemia.
Yes, you are right. So because there is hyperinsulinemia, once the cord is clamped, baby can develop sudden reduced blood glucose levels, hypoglycemia episodes. So how do you prevent fetal hypoglycemia? How do you prevent neonatal hypoglycemia episodes? Mother has to breastfeed the baby within half an hour. So as soon as the baby is born, so first thing is you can check the blood. Usually the cord blood sugars are checked. And second thing is you ask the mother to breastfeed the baby within 1 hour of birth. Okay. Then every hourly blood sugar is monitored in the first 4 hours for the baby. So in the initial first 4 hours, the blood sugar values are monitored every hourly in the babies born to GDM to check for the hypoglycemic episodes. Okay.
Okay, ma'am.
So to prevent polycythemia and hyperbilirubinemia, you are doing early card clamping. Okay, because babies have some amount of hypoxia leading to polycythemia. Macrosomia babies, if there's a macrosomia babies, you usually do early card clamping. Otherwise, well-controlled GDM, you can do as regularly, you can do delayed card clamping. Because there is a polycythemia, there is hyperbilirubinemia later. Okay, so that's how you explain. Okay, so what, you know what is shoulder dystocia when you call it as shoulder dystocia?
Yes, ma'am.
So when you call it as shoulder dystocia?
When the shoulder is not delivered, I mean, more than 1 minute after the delivery of the egg, or if we require any maneuvers to deliver the shoulders, then it is called the shoulder dystocia.
Very good. Okay, so you're right. Perfect. So either when the head is delivered and even after 1 minute, the shoulders have not been delivered. So within 1 minute of the head of the baby, the shoulders are not delivered, then it is shoulder dystocia. Or also it is shoulder dystocia when you need additional maneuvers to deliver the shoulders. Okay, so that is called as shoulder dystocia. Do you know any maneuvers to be done when there is a shoulder dystocia happens during intrapartum?
Yeah, first maneuver,
Yeah.
foot screw maneuver, Rubin's maneuver, Jack Mears maneuver, and Gaskin's maneuver. If the last maneuver is a Zavanella maneuver, where we
Savanellis, yes. So can you just tell me one maneuver? What is the MacRoberts maneuver?
yes, ma'am. The limbs of the lady is flexed against the thigh, and then the thighs are abducted, so the perineal size increases. So that.
Yes.
Hello.
Good. Yeah. So there is hyperflexion. Suddenly there is a hyperflexion and abduction of the thighs over the maternal abdomen, which leads to upward rotation of the pubic symphysis. So there is a slight 1.5 to 2 centimeter increase in the outlet diameter, so that shoulders can be released. So the other person has to give suprapubic pressure. Okay, so 90% of the shoulder dystocias will be relieved by MacRoberts maneuver. Okay, yes, that is good. Okay, any other doubts you want me to clear? That was a very good presentation by Neethu. It was well done. Okay, nicely presented. You have done very bold attempt to present. Nicely done. Okay,
Thank you.
thank you. Any doubts you want me to clear? I'll tell you. Antepartum management, I'll just revise once. Okay, I'll just revise once because your case is actually late term pregnancy, so we couldn't discuss antepartum management in detail. I'll just one brief guideline I'll give you how to manage antepartum GDM mothers. So if the gestational diabetes mellitus, we are sure about the screening, universal screening. That is, all the patients have to be screened. It is not selective screening. It is universal screening. The method is the DIPSI method, 75 grams, 2 hours later, 140. Cutoff is the GDM. Okay, you're sure about that. So once patients are diagnosed to be having GDM, the first line of management is medical nutrition therapy, 2 weeks of MNT. So the patient need not be admitted directly in the initial period of gestation. When she is diagnosed at 28 weeks or when she is diagnosed at 12 to 14, you need not admit the patient. Just send them to a dietitian, tell them regarding moderate exercises, or if they're not aware of the exercises, they can actually go in for at least walking. So 2 weeks of walking. Okay, so 2 weeks of diet and exercise. After 2 weeks, you get only PPBS. If PPBS is more than 120, it's an indication to start other medical line of drugs. If it is less than 120, she'll continue with her MNT. So patients with medical nutrition therapy will continue with MNT and they'll come once in 2 weeks for ANC checkup up to 28 weeks of gestation. So what we do earlier for low risk pregnancies, once in 4 weeks, they come for ANC checkups up to 28, right? Whereas in GDM mothers, we ask them to come once in every 2 weeks up to 28 weeks. After 28 weeks, they have to come once in a week. So MNT mothers have to come once in a week after 28 weeks till term. Okay. Anytime their blood sugars are abnormal, they need to be admitted for the insulin management. Okay. So this is how you manage them. But you have to, if they're not uncontrolled on MNT after 2 weeks, or if the patient is diagnosed that she is GDM for the first time at term, or if her blood sugars are more than 200 in the initial testing, it's a direct indication to start with the medications like insulin therapy. In that case, you have to admit the patient, start with the insulin. So the insulin recommended by Government of India is a combination insulin of short acting and intermediate acting, mixed preparation. 30-70 mixture is recommended. You usually start with 4 to 6 units per day. Okay, and get her after admission, you start with 4 to 6 units of insulin. We start with the lowest dose, 4 to 6 units of insulin per day. Then you get her blood sugar every third day after 48 hours. Every third day you get her blood sugar done, and you titrate the insulin depending upon her fasting blood sugar and postprandial blood sugar. So that is using a 6 sugar sliding scale method. You do that. You fix her insulin. So once you fix the insulin dose, you can discharge the patient and advise her regarding the how to take insulin, how important is to continue with the diet and exercises, and also mention regarding the hypoglycemia episodes. Okay, so you explain regarding the hypoglycemia episodes and what has to be done during the hypoglycemia episodes. Patients who are on insulin will come for weekly antenatal checkup throughout their pregnancy. Okay, so patients with medical nutrition therapy actually were coming once in 2 weeks up to 28. After that, once in a week. Whereas once you start with the insulin, they have to come for a weekly antenatal visits, and every week you'll be getting a FBS and PPBS blood sugar values. Along with that, you will continue with the fetal monitoring test. So fetal surveillance test also has to be done, including a anomaly scan, then followed by growth scans every 4 weeks has to be done for these patients. And once they complete 32 weeks, you will be doing NST. Okay, non-stress test also has to be combined for all the GDM mothers. Once in a week, they have to get a NST done. Okay, so this is how you continue with the management, and pregnancy will be terminated for if the patients are purely on MNT, never they needed insulin throughout the pregnancy. You can wait till expected date of delivery, but never allow the pregnancy to overrun the dates. Okay, patients who are on drugs or insulin, pregnancy will be terminated by 38 weeks. Okay, pregnancy may have to be terminated very early if the patient has got associated preeclampsia, associated vasculopathy, or she has history of previous recurrent stillbirths. In those cases, you may have to terminate the pregnancy early depending upon your ultrasound Doppler findings. Okay, so intrapartum management, we are sure, I think. There is no doubt in the intrapartum management. Okay. Yeah, one doubt is, ma'am, can we tell GDM is a risk factor for HTP due to, yes, preeclampsia risk is more in gestational diabetes mellitus mothers, particularly in over diabetes. Okay, so one is it is placentomegaly and there is associated vasculopathy also. Yes, so generally the risk of preeclampsia, the risk of hypertensive disorder of pregnancy is around 5 to 8%. Okay, whereas in patients with diabetes mellitus, it's around 20 to 25%. It is definitely increased. So hypertensive disorder of pregnancy is a complication of GDM mothers. And other one is hypothyroidism. Hypothyroidism is also common in mothers with GDM. HDP and hypothyroidism both are common. They're quite common complications in the GDM mothers. Yes. Yeah, one is placentomegaly, the other one is direct glucose-induced vascular endothelial dysfunction. Both can lead to hypertensive disorder of pregnancy, HDP. Okay. Yeah. Any other doubts?
Shall we conclude the session now?
Yeah. Yes, we can go ahead and conclude.
Okay. Thank you so much, ma'am. It was a very interesting and wonderful session. You explained all the concepts so clearly and in depth. And we're very eager to learn from you in the future sessions as well. Thank you very much, ma'am.
Yeah, sure. It was really a wonderful experience for me because first time I have taken online class. I have been doing classes, seminars basically for the UG classes, but first time I have done interactive session like a case presentation here. It was a wonderful platform. Thanks a lot. And Neethu has presented really well. And many of you have asked so many doubts. It was quite an interactive session. I liked it. I liked a lot. Thank you. Thank all
Thank
of you.
you so much, ma'am.
Thank
And
you.
thank you very much, Neethu. You come forward and you presented the case. It was
Yes.
really good. Thank you, ma'am.